Institute specializes in state-of-the-art advanced spine treatments for curing back and neck pain, as well as radiculopathy, myelopathy, should patients have it, which is nerve root problems or spinal cord problems. And our patient today does not have really any significant radiculopathy or myelopathy. He does have back pain. And we've determined that his back pain is coming from a herniated disc, most specifically two herniated discs, one at L4-5, one at L5-S1. And he doesn't just have a herniated disc. When I look at his MRI, he has what I call internal disc disruption. Internal disc disruption. And that is not a term that I came up with. It's a term that was created many years ago, and it's been well known in the medical community, and particularly with doctors that treat back pain. This is Dr. Deuk Majin. Are you okay? I'm going to get started, okay? Our patient is awake. He is laying on the table prone on his belly, and we're going to try to keep him as comfortable as possible. That's my hand feeling around, okay? If you have pain, just say ouch. But just try to relax as much as possible, and I'm going to keep you as comfortable as I can, okay? All right. If you feel pain, say ouch, and I'll give you some more numbing medicine. Don't move your body. So you're going to feel a little stick and burn. That's normal. That's just the medicine going in. Okay? That's the numbing medicine. Don't be upset or alarmed. Just give it a minute to work, and you'll feel better. Okay? I apologize. 7 cc's. Remember, if you feel uncomfortable, you feel pain, you say ouch, and I'll give you some more numbing medicine, okay? Now, he has internal disc disruption at L5-S1 and L3-4, and you could see it on the MRI, okay? And we tested his discs just to see if they were causing his pain, and certainly they were. They were causing the pain. We know that because we did a discogram already. And we found that two discs, L4-5, L5-S1, were causing his back pain, his typical back pain. So if we fix those two discs, we should be able to get rid of his back pain. Shot. Lateral. So we're going to use an x-ray machine to navigate into those two damaged discs using a spinal needle. Once we're there, we're going to do a discogram. And then we're going to put a guide wire and use the guide wire to navigate additional instruments in. Those instruments that we're going to use will be used to guide the endoscopic tube. Shot. I need you to line up that end plate better. It's not horrible, but I think we can do a better job at 5-1. Shot. I like it. It's better, but it's still not perfect. I think you're almost perfect there. Shot. A lot of arthritis, a lot of bone spur. Shot. That's really actually pretty good right there. He does have a high iliac crest. Shot. All right. Let's see. Shot. Wonder if we're encountering AP, the iliac crest. What's that? Is that uncomfortable? I'm just putting pressure on your back with my hand. I'm not doing anything else. We're trying to navigate into that disc. So I think it's just like the biggest facet complex I've ever seen. Extremely sclerotic. Let's go back to a lateral view. You're doing good. Everything is okay. The first step here, we have to have you awake, and just to make sure it's done safely. And I have to get by all these bone spurs you've got, because you got quite a bit. Shot. I know that's uncomfortable. Where do you feel that? Let me have some numbing medicine. Shot. Where do you feel that? Huh? Your left hip? All right, so maybe we can help him with a little something. Numbing. I need him not jumping around, so he's a little bit too anxious right now. Huh? Yeah. What is it? I don't need him knocked out, but I need him not so responsive. Shot. Yeah, once he starts moving around, we lose all of our landmarks. Shot. All right. Let's wag it just a little bit. I want to get those pedicles lined up perfectly at 5. The 4s look good. It's the 5 I'm a little bit worried about. Shot. Let's see if we can do a little better. 4-5 looks amazing. It's just 5-1 that doesn't look so good. See what you can do. Shot. Let's go, Jordan. Move, shot, till you get it right. I think that's pretty good, Jordan. What happened there? Okay. Shot. Give me an AP. Need to go more anterior. Shot. All right, back to a lateral. We're definitely missing the iliac crest. Shot. Shot. And for those of you watching, L5-S1 is always the hardest to get into. Are you comfortable? All right, give me an AP. So we're pretty close to the foramen. There's a little tricks you have to do while you're doing this to make sure you really just slide in just underneath the facet, which is really the optimal place to be. Is he awake? All right. So what I like in the beginning is just something to calm them so that every little piece of pain doesn't make them move and jump and react hemodynamically. So, but I don't want them asleep. I need them still awake. All right. Shot. AP, I mean lateral. Let me know when he's responsive. we're going to start, we'll probably get a little closer at L5-1, then I'll start 4-5. Shot. That it right there? Yeah. Shot. Shot. All right, I'm just going to keep it there. I feel pretty good about our entry point. So we're making an incision. And although really there's no such thing as bloodless surgery unless it's radiation you're giving, this surgery is pretty darn close to being as bloodless as you can get.
We have a question.
Sure.
One of our viewers is wondering, if the herniated disc is in the lumbar spine, can it cause muscle spasms in the upper and mid back?
If the herniated disc is in the lumbar spine, can it cause muscle spasms and pain in the mid back? The answer is no. It cannot. Herniated discs cause pain really where they are. Sean? And that's about it. They can cause muscle spasms in the lower back, but not the upper back. Shot. So if you have a L4-5 herniated disc, shot, you can get muscle spasms at L4-5. You know, L3-4. You know, if your herniated disc is right here, you can get muscle spasms in the lower back in this area from about L2 down, but it would not cause thoracic muscle spasms. Is that where we are right now? Shot? All right, so I need him more awake so I can finish placement. If you want to let him wake up a little bit. Are you awake? Yeah? Are you comfortable? Shot. Shot. Where do you feel that, AP? Not down your leg, right? I couldn't hear what he said. So that needle is in perfect position. I'm going to advance it into the disc. All right, and let's go back to a lateral view, please. So the L4-5 disc we've accessed. It's actually a bigger disc than 5-1, taller, more normal. And the L5-S1 is the one we're working on right now. So I needed him more awake before I could progress there. Shot. You awake? Any pain? Left hip? Shot? Definitely getting through all the arthritis of that facet joint. I want to try to get that 5-1. I think we could do better. So 4-5 is fine. Let's wag for 5-1. We need about 2 or 3 degrees. So pick one way. Shot. I think that's better. That looks good. That looks a lot better to me. What do you think, Luis? Right? All right. Are you awake? Shot. Hey, AP. We're almost done with what I need to do before I put you to sleep. Now, I was telling you all before this surgery, we did a discogram. We wanted to see if these discs that we're treating right now are actually the cause of his pain. Go back to a lateral. So, you know, and the reason we do a discogram is not just to confirm that a disc that we think is causing the pain, but it's sometimes we do it to rule out discs that we we're not sure. You know, we're just not sure if that other disc is causing pain or not. And we did that for him. We were concerned about a disc called L3-4 shot, which is the one above, because it looks bad on MRI. And it turned out that it was not causing his pain. Shot? Where do you feel that, Shot? In the back? Shot? Huh? Shot? Ah, damn it. Can you lower the fluoro, please? Raise the table. You keep getting my hand in the beam. And it's starting to get hot. All right. Shot. Shot. Are you comfortable? Shot. That's better. Anything in your leg? No. Nothing? No. Shot. That's the back of the disc right there. Legs good? Shot. Shot. Where? In your back. In your back, AP. But not down your leg. All right, we're almost done with positioning. We'll do our discogram and then we'll be able to put him to sleep. We're right there. It's beautiful. We just need to pump it in. Go lateral. What size gloves did you give me? 8.5, 8.5?
Yes, sir. Do you want 9?
I just feel tingling in my finger, but I think it's too much, too tight for some reason. You know, these gloves are unreliable in terms of their size sometimes. Huh?
Right there.
Yep, I believe you. Shot. Huh? That's it? Interesting. Shot. We're so close. Where do you feel that? In your back. In your back. Okay, that's fine. Your back is fine. Just don't want it down the leg. Shot. All right. Try one more time. Shot. A little higher trajectory. Shot. Huh? Where? That's what I was worried about. Shot. How about now? Is it better? Not down your leg? Nothing? Where? Back. In your back? Where? Where exactly? Your thigh? All right, but not down your leg. All right. Well, it's unfortunate. We're not. Huh? Oh yeah, the angle is always difficult. 5-1. Most endoscopic surgeons that do this, there's only probably 10 in the world that do transforaminal endoscopic surgery. They don't even do 5-1. They just They're too hard to get to, but I usually get it, like probably 98% of the time. I'm gonna get it in his case, but I wanted to do the discogram. But I'm not gonna be able to do the discogram unless I can curl around and get a little bit better approach. But I can still access the disc right now through the foramen, which is good, so I can still do the procedure, but I'd like to do it with a discogram first. So I may try one more time and then just settle for the access and not the discogram, because the angle is just a little bit too steep, because his iliac crest is a little bit too high. So we'll try one more time. Shot. Are you comfortable?
Yep.
Shot. That should be the facet. That's a nice trajectory. Shot. Just looks good. Anything? Yeah. Shot. So it doesn't want to bounce. Where?
Your leg?
No, just where you putting it in, I guess.
Just in your back. No leg.
No leg.
Okay. Are you comfortable?
Yeah.
We're just going to do 4 or 5 then.
Oh,
How bad is that on a scale of 1 to 10?
probably,
10 is the worst pain.
yeah, right across my back.
Is that a 10 or what? Yes?
Yeah.
All right. That was 4 or 5. We did an evocative discogram, 10 out of 10. That's your typical pain you get?
Yeah, I get sharp pain right here.
Well, that'll be gone when we're done, when you wake up, and I think you'll be very happy with the results. So we're going to put you to sleep now, okay? Go ahead and just count from 1 to 100 out loud for me. Don't move your body. You need to lay still. Go ahead. Count out loud, 1 to 100. Count so I can hear you.
7, 8, 9, 10.
Keep going. You're doing great. Everything's okay. Shot. Good. So we'll remove the spinal needle, leaving the guide wire. And then we've already made our incision in the skin. We're going to bring a dilator down. The dilator is going to basically spread the tissues, shot, that allow us to gain access to the disc space. Remember, we're going through the neuroforamen. We're going to be going in. If you watch the last surgery I did, which is a 2-level lumbar T-lift, we went through the foramen also with the cage, remember? And we went into a space called Cambin's Triangle. We're doing the same thing. We're going through Cambin's Triangle. I did not discover Cambin's Triangle. Dr. Parvis Cambin did. And it's called the safe zone. That's the other name for it. And Dr. Cambin was really the first person to use that to gain access to the disc through the foramen. Shot. Dr. Cambin was faculty in Pennsylvania at Pittsburgh. So we're in. I'm going to advance it a little further. This dilator, shot. Looks like a pencil. We're going to put it into the disc a little more, shot. I like it really anchored in there. At least 2/3 of the way from back of the disc to the front. And now, just so you all can see, this is how we do the entire surgery, through this little metal tube. This is true endoscopic surgery, okay? This is not an endoscope. This is a tubular retractor used in spine surgery all the time. Tubular because it's shaped like a tube, retractor because it pushes away the skin and it pushes away the muscles, so it holds them at bay. So I could put this endoscope in. The endoscope is going to go down the tubular retractor, and it's going to allow me to see inside the disc. So we're putting the tubular retractor in. Don't try this at home. Shot. Shot. I'm inside the disc now. Good. And we're going to take the dilator out. This is what we use to dilate and do the surgery with initially. We found the way through the dilator. Tubular retractor goes over the dilator. We're going to move the fluoro out, and I'm going to gradually bring the tubular retractor backwards as I repair the disc. Specifically, what am I repairing? I'm repairing the annulus, the annular tear. Okay? The annular tear. All right. You want to do my wrist? So the endoscope is a true endoscope. There's a lot of spine surgeons that say they do endoscopic surgery, but they don't. They do fake endoscopic surgery. Why would they say that? Because everyone wants to do endoscopic surgery. It's the newest, most advanced type of surgery, but they actually don't do endoscopic surgery. To do endoscopic surgery, you have to have an endoscope, and very few surgeons know how to use this equipment. They haven't been trained on it, and their hospitals don't own it. But they still call it endoscopic because it's sexy. That would be like me singing a John Bon Jovi song and calling myself a rock star. Well, you're missing the fans, missing the millions of dollars in payment, missing the stage, missing the rest of the band. You can't be a rock star unless you're a rock star. You can't be an endoscopic spine surgeon unless you really use an endoscope. Right, Luis? All right, so we're inside the disc. You can see the first part of the herniation right there. And the blue color comes from a blue dye that I put in there. Grabber? Wait, what am I doing? Yeah, I don't want this yet. You know better than that. All right, that IV pole is in my way, doctor. Thank you. Here's a piece of herniated disc. So we're inside the L4-5 disc right now. I started with L4-5 because we were already in there, and I wanted to do the discogram, which I did. And the L5-S1, I can't do a discogram because my needle isn't in the disc. It's right at the beginning of the disc. So I'm going to have to use an alternative technique to get into the disc that involves bringing the guide wire and dilator down right to the surface of the disc and then entering the disc under direct supervision with X-ray help. Rather than going over the guide wire, which is anchored inside the disc, I'm going to have to go over the guide wire anchored in the foramen right outside the disc. So it's a little bit more challenging to do, and I want to get this other needle and guide wire out of the way before I even try. So I just want to be able to focus on that disc. All right. So this is all part of the herniation. A lot of scar tissue, the white stuff, and the blue stuff is herniated, degenerated disc material.
I have a question.
Sure.
One of our viewers is wondering, can pain in the knees be the result of a lower back injury?
Can pain in the knees be the result of a lower back injury? That's the question. So a lower back injury itself will not cause pain in the knees. Pain in the knees is usually caused by a problem in the knees. Either a meniscus problem or arthritis of the joint or inflammation in the joint, could be from an infection or an injury, or a ligament tear like an anterior cruciate ligament or posterior cruciate ligament tear. So the answer is generally no. Pain in the knee is not caused by a back problem. Now, a back problem could cause pain shooting down from the back through the posterior thigh past the knee. But pain inside the knee never comes from the back. Now, could you get pain in the knee from a back injury secondary? Yes. So, for example, standby laser. If you injure your back and it makes you walk funny, then you could wear your knee down, and your knee could become a problem secondary to your back injury. Okay, if you don't treat it soon enough, your back injury. That's why I recommend anyone with chronic back pain longer than 2 to 3 months, they get it fixed. Otherwise, you're going to start getting hip problems, knee problems, all kinds of problems. That was a chunk. Huh? So, don't put off getting your back injury fixed. That's what I would tell you. Because you can get other problems in your hips, knees, from walking badly, favoring one side, if you have a back injury, and that will cause your knee to wear out. So I don't know if that answers your question. So you can see the laser fiber at 12 o'clock. It's a little glass electrode. And basically I'm using this glass, the tip of the end is where the laser energy comes out of. And you can see how it just causes the tissue to break apart. Now, this is not working just in air. There's water, liquid all around. I use cold, refrigerated, normal saline. Okay, right? Or lactated ringers is fine. Whichever one is available. These days there's so many pharmaceutical companies crying and saying they don't have supplies, and they want to raise the price for us by 3, 4, 5 times the normal price. So the only reason they're able to do that is because they're basically telling everyone that they're short supplied, right, Luis?
Yes, sir.
We know it isn't true. But it allows them to jack the price up. The law of supply and demand. Free market. The only problem is that they lie about their supplies, saying that they're compromised and low. They basically do what Enron did in California back in the 80s. Who remembers Enron? The big Enron scam. Enron was I don't even know what they were, to be honest with you, but they owned energy power plants that supplied power in California. And they used to fake power outages. They used to fake that the nuclear power plant went down. They would have several of them, so they'd shut one down so they could jack the price up of electricity. See, the California Board of Energy, they would only allow a price hike if one of the power plants was down and had to be repaired. You know, so you could pay for the repair. So Enron would fake power outages so they could jack the electricity price up 10 times the normal price. It's disgusting. So the pharmaceutical industry learned from Enron, and now they jack their prices up. And they fake that they have shortages of saline, which is salt water basically. Right, Luis?
Yes, sir.
We've never had saline shortages in the history of medicine until the last couple of years, when it became profitable to have shortages. Does that make any sense? This is the kind of stuff that happens that needs to be regulated by the government. And the government is not doing their job. They want to regulate the doctors, and they charge me $12,000 to have a nurse come out, look at my surgery center for a day and say, you're doing a great job looking at the charts. I have to pay that. That's called the AAAHC reaccreditation survey. And I've got to pay $10,000 for a TV monitor in my operating room when I could buy it from Walmart for $400. But but I need a medical grade. So unfortunately our government is focused on the wrong things, intentionally distracted, of course, paid to be looking the other way. All right, I'm trying to take out these pieces of herniation, and there are just lots of chunks. How is he doing? Is he okay? Uh-huh. Is that a yes, no, maybe so? Yeah, you can let him lighten up a little bit if you want. He's not really moving or doing anything from my standpoint.
What?
He's not moving or anything from my
No,
stand.
no, it's okay.
You can lighten him up a little if you
Yeah,
want.
I thought that, so it's okay then.
This is a very interesting disc, by the way. I didn't ask him how long he had his pain for, but I did in the history, but I don't have that available. Okay, over 10 years I'm being told. Thank you. And the reason I say it's interesting is because when I look inside his disc, I see areas where there's actually scar tissue from chronic inflammation. And I see areas where there's disc material, nucleus, you know, kind of areas where the nucleus has been, but it's been dissolved away by inflammation. And then areas where the herniation's still there. So it's like, kind of like a battle field where you have areas where there's still battle going on and areas where there are just dead soldiers, you know? Like right here is an active battle. This is the annulus right here. So we call that heterogeneous. It's a heterogeneous appearing disc. Hetero means different. Homo in Latin means same. So heterogeneous means different appearance, heterogeneous appearance. Different appearing zones of the disc herniation. Some old, some new. Now once again, he did not have a lot of leg symptoms, so he did have some weakness that he wasn't really aware of that we found on exam, but with dorsiflexion. But he didn't have really sciatic pain. He had pretty much just chronic back pain across his lower back at L4-5 and L5-S1. Now we didn't know if L3-4 was also affected, causing pain, so we did a discogram before surgery, Dr. Patel did, and we found that L3-4 was not painful. It was not causing his daily pain. So we left that disc out. We didn't treat it. We're not treating it today. There's no point in treating a disc that's not causing symptoms. Proper spine surgery is not about fixing bad looking discs on MRI. It's about fixing painful symptomatic discs, ones that need to be fixed. All right, that's pretty good. I'm just about done here at this one. I still want him asleep because I'm gonna do the next one too while he's asleep, okay? I apologize for the poor visibility. I can't control that. That's just a little bit of bleeding. And when I mean little bit, I mean tiny, tiny, tiny bit. Was he on like baby aspirin or something at one point? All right, take this 10 days ago, perfect. There's still some residual effect. All right, I'm done with 4-5. Let me see here, one more thing. Yeah, it looks good. Okay, there's the nerve right there at the corner, that white thing, it looks good. Okay, I'm gonna get the water out. And the reason it's a little bit hazy once again is we're dealing with some bleeding in there. Not much, just a tiny, tiny bit. Okay? Scope off. And we're going to go for L5-S1 next. I like it rolled up tight. So we're going to put pressure for a few minutes because we want to stop the venous bleeding. There's always a little bit of bleeding with veins. And let's get the fluoro in. We're going to go back to the L5-S1 level and try to do that one next. Now, because we couldn't get into the L5-S1 disc because his facet joint is so big and hypertrophied, it's pushing the needle downward. There's a chance we won't be able to get that one done. I would say right now maybe a 25% chance. Just based on everything I know, if I had to guess. If you do this kind of surgery in the future, make sure you put pressure on the muscles for a little bit. What you want to avoid is the development of an intramuscular hematoma. Although an intramuscular hematoma is not life-threatening in any way, unless it's ridiculously big, he'd have to look like Quasimodo. But really the big issue is that as the blood clot breaks down over the ensuing 2 months, it releases breakdown products of hemosiderin, and it's very irritating and pro-inflammatory, so it's going to cause some muscle soreness, which our goal here is to get rid of pain, not create new pain. So some bleeding is inevitable, but as long as you just take your time and you apply pressure on the paraspinous muscle that you just went through, then if you're patient enough, you give it time, you should be able to stop that bleeding. It should be minimal, and the patient won't have any irritation. I used to not do that, but then I had one patient a long time ago, about 14 years ago when I started doing these, and I remember he was a performer on a cruise ship for Disney, and he had the laser surgery. He was very happy, but he had soreness in the muscles for like a month afterwards. We had to do trigger point injections to try to make him more comfortable so he could do his job. And I realized what happened was he had a hematoma, a small intramuscular hematoma. So ever since then, I always put pressure, and I never got another one in a patient. That was over 1,000 cases ago. So if you want to become a great surgeon, you have to understand your results and why they happen the way they do. Go ahead, put pressure. And do everything you can to improve upon them. All right. I think we should go for it. I think it's safe to try. I need the guide wire. Now remember, we're not in the disc this time, so we're going to have to just plant the guide wire. Shot. And we're going to have to take out this needle. Shot. And hope the guide wire stays put. Do more than hope. We have to monitor it and make sure it doesn't move substantially. Shot. Okay. And this will guide me down through the foramen like I want it to. Shot. I need a knife. I just need to open that tiny bit more.
You want me to keep the...
Yeah, yeah. Shot. All right. Shot. No. Shot. Shot. So this will take me to the foramen below the root. Shot. Shot. Just about there. How's he doing? Shot? Not happy with me, I'm sure, right now. Wait, shot? Yeah. Let me have that. Shot? Yeah. Where's the MRI? I don't know. This feels really weird. Yeah. Come on, guys. We need to keep the MRI up. Why would it not be up? Oh. That's a good reason. This feels like bone down here. I think that's what we're seeing on the MRI. We're right on the disc. And yet it feels like bone. Hear that?
Yeah.
I don't think there's, I think this is solid. I think we're pretty much done, doctor. Because this is appears to be fused. Hey, I need the roll.
The roll?
Put pressure.
Yes, sir.
You know what we can do? Give me that needle for the epidural. Oh, nice. That explains why we couldn't get in. Pressure. Right there, go. Good job, everybody.
Yes, sir. Lights on, please. Freeze off. Machine off, please.
All right, if you have questions, type them up and I'll answer them for you in the conference room. We're done. Why don't you show them the incision there, Luis? I got a rate tech off the field. I'm going to call EBL 5 mil. Sean, I'll be right there.
All right, everyone, Dr. Deuk will be joining us shortly to answer any of your remaining questions. If you take a look on the screen now, we have the patient's MRI report up. You can see that at the level that we just operated on, L4-5, there is a large diffuse disc bulge identified by the MRI. Keep in mind, MRIs are only one diagnostic tool that we use when deciding on what surgery will be best for a patient, but in this case, the MRI report does confirm what we suspected as being the source of their pain, so hopefully this surgery will cure their preoperative symptoms. All right, everyone. Thank you for joining us for the post-op Q&A. We have Dr. Deuk in the room with us. He's going to discuss what happened in that recent surgery you just saw and also answer any of your remaining questions. So go ahead and type them in the chat now.
Well, thank you, Sean. So we're wrapping up a Deuk laser disc repair. This patient had two discs that we thought were causing the pain, L4-5 L5-S1, based on a discogram Dr. Patel did before surgery. And some things to note, the discogram he had before surgery showed that the L4-5 disc was a 7 out of 10 pain, but when we tested it today, he was a 10 out of 10 pain. So I think I just got a better discogram than Patel. But clearly it was a very, very painful disc. That number L4-5 disc was very painful. So we fixed that today with the laser, and I think that pain's going to be gone completely. Tried to get into L5-S1, but it was weird because the disc itself was calcified pretty hard. And I'm thinking that disc may actually be fused. So I was unable to get in there to do the laser. We tried our darndest, but we couldn't get in. But that's actually a good thing if it's already calcified and fused, because that means it's not moving, so it won't be causing any pain. That said, we lost very little blood, as you can see. We did everything through a tiny incision, size of a Band-Aid, and I think this patient's going to do fantastic. I expect his pain to be gone. We'll see how he's doing tomorrow when he comes in. Now, you got a chance today, if you watched all of our surgeries at Deuk Spine, to watch a 2-level L4-5 L5-S1 open decompression infusion compared to a Deuk laser disc repair through a 7mm incision. I can tell you the first patient, she's still here, she's almost ready to go home, but she's having pain. No surprise. No matter how good you are doing a decompression infusion at L4-5 L5-S1, your patients are going to have pain because you're having to manipulate the muscles. And all this minimally invasive spine surgery you read about and hear about, where these surgeons are making multiple small incisions, I got news for you folks. I learned how to do minimally invasive spine surgery as part of my training. As a matter of fact, I learned from one of the forefather pioneers in the United States, Richard Fessler. Dr. Richard Fessler is at Chicago now, but he was at UF in Gainesville and trained me. The point I'm trying to tell you is that we also had Kevin Foley, who, was quote-unquote the inventor of the Metrix tube with Medtronic. He came over and trained the residents at UF. I learned minimally invasive surgery from many different surgeons in my training. These minimally invasive techniques all have one thing in common when it comes to the muscles. They all damage the muscles severely. And these minimally invasive techniques are supposed to be more muscle sparing, less damaging to the muscle, yet they actually damage the muscles almost as much as the traditional midline incision surgeries. Now, I will tell you this, there are surgeons that, and most spine surgeons, just don't even think about the muscles or care about them, and they let them be damaged severely during surgery with their poor technique. So the minimally invasive surgeons came along and said, we damage the muscles less through a paramedian incision. But those paramedian incisions also damage the muscle, but just not as much as some of the sloppier midline surgeons. And then you come in and you do a midline surgery properly without damaging the muscle at all, like our surgery today, and you get muscle inflammation and swelling as a result of the retraction. But the damage to the muscle is very minimal, but you still have significant pain in the patient. So all of these surgeries, open back surgeries, posterior cervical, posterior lumbar, they all have one thing in common, and that is muscle pain after surgery. That's the cause of the pain during recovery. The Deuk laser disc repair that you just watched will have no muscle pain. The patient will be basically back to normal tomorrow when they come in, whereas the fusion patient will have severe pain and spasms in their muscles for weeks, if not months, after surgery. So the recovery is much faster, better, less painful with the laser. Our patient will take Tylenol, and that's it, maybe for one day. The fusion patient, on the other hand, will be on powerful narcotics for probably a month, is what I would guess. That's the average. And you'll see the difference tomorrow when we video both of them. Other than that, I guess we don't have any questions? Or, oh, we have one. Here you go.
So one of our viewers is wondering, how did the disc at L5-S1 fuse completely on its own?
Somebody is asking me, Dr. Deuk, how did the disc fuse on its own? That's a great question. We don't see that very often. Whenever we see discs that are fused, almost always it is from a surgeon fusing the disc. So there is a process, though, in some patients known as the bamboo spine, in which case discs will auto-fuse. And this patient may very well have what's called HLA-B27 ankylosing spondylitis. It's a spondylopathy, seropositive. Basically, this patient has an autoimmune condition where they basically fuse their own discs. It's extremely rare, and I probably see maybe at most 1 or 2 patients a year out of thousands that have this. And I'm wondering if this patient doesn't have that condition. I don't know that they do or don't, but that would be my most logical guess. If this was a board question, you know, it would be HLA-B27, bamboo spine, ankylosing spondylitis as the disease condition. So that's what I would say would be the most likely cause. Okay, but I can't tell you why because I don't know 100% why. But very good question. And thank you for being so observant and watching. All right, Sean, I don't have anything else to add. We'll have both of our patients, I hope, tomorrow do videos so you can do a comparison post-op. Thank you.